الرحمن الرحيم. Pulmonary disease in systemic lupus erythromatosis. Systemic lupus erythematosus is a multi-organ autoimmune disease mainly affecting the woman. The double-stranded DNA antibodies present in high titers, and this may be pathogenic, can also get a drug-induced lupus erythematosus syndrome. That improves on stopping the drug. Pulmonary disease, lung, vasculatures, pleura, and diaphragm, often seen in SLE and may be a presenting feature of the disease. American Colleague Rheumatology Classification of Rheumatology. American Colleague of Rheumatology Classification for systemic lupus erythematosus include the following: systemic lupus erythematosus suspected or expected if four or more criteria are present serially or simultaneously during any interval. The criteria include the following: malar rash, discoid rash, photosensitivity, oral ulcers, non-erosive erythematitis more or equal to peripheral joints, pleuritis or pericarditis, renal disorder, proteinuria more than half gram per 24 hour, or 3 positive persistently, or cellular casts, neurological disorder such as seizures or psychosis, having excluded drugs or other causes, hematological disorder such as hemolytic anemia or leukopenia, that is to say white blood cells below 4 million per liter on 2 or more occasions, lymphopenia, meaning lymphocytes 1.5 million per liter on 2 or more occasions, or thrombocytopenia, that is to say platelets below 100 million per liter, immunological disorders in which raised anti-double-stranded DNA antibody, anti-smooth muscle antibody, positive finding of anti-phospholipid antibodies, anti-nuclear antibody in raised titer in absence of drugs known to be associated with drug-induced lupus. Now we'll go to the pulmonary manifestations of systemic lupus erythematosus. Pulmonary manifestations include pleural disease, which is common and found in up to 50% of patients, often asymptomatic, but may have dyspnea or pleuritic pain due to pleuritis with pleural rub. Pleuritic pain may also be musculoskeletal. It's often bilateral and exudative with neutrophilia or a lymphocytosis in chronic effusion, can be hemorrhagic, and rarely develop fibrothorax. Pleural biopsy finding is non-specific, need to be need to exclude other causes for effusion. If symptomatic, may need treatment with nonsteroidal anti-inflammatory or steroids. Atelectasis. Atelectasis and systemic lupus erythematosus associated with pleurisy or effusion. A diffuse interstitial lung disease occurs in 70% of patients of systemic lupus erythematosus and can be found in CT or autopsy series, but usually mild and asymptomatic, radiologically, usually non-specific interstitial pneumonia, and only 5% develop clinical disease similar to usual interstitial pneumonia with dyspnea, cough, and basal crackles, may be associated with pleuritic pain. Pulmonary function tests show restrictive defect with reduced KCO and rarely progressive and severe. Acute lupus pneumonitis occurs in below 2%, severe illness with mortality rate more than 50%. There is cough, dyspnea, fever, pleuritic pain, hypoxia, and widespread crackles. Chest X-ray shows infiltrates, which may be widespread, histologically non-specific acute alveolar injury, and need to exclude infection, pulmonary edema. Treatment include steroids and cytotoxic drugs may be necessary and may have good response and can progress to chronic interstitial pneumonitis. Pulmonary hypertension due to pulmonary vasoconstriction rather than pulmonary vasculitis, commoner in those with rhinoid phenomena and associated with poorer prognosis, 50% 2-year mortality, diagnosed on echo, and need to exclude pulmonary embolism as a cause, especially in those with antiphospholipid antibodies. Treatment as for idiopathic pulmonary hypertension. Pulmonary embolism, commoner in the 20 to 30% of patients with antiphospholipid antibodies. Shrinking lung syndrome, shrinking lung syndrome, dyspnea plus or minus episodic pleurisy caused by reduced lung volumes and poor respiratory reserve, probably due to diaphragmatic muscle weakness, and small lungs appear on chest X-ray, normal lung parenchyma on CT, restrictive lung function tests with normal or high KCO and may improve with steroids. The alveolar hemorrhage in systemic lupus erythematosus is rare but may be life-threatening and can have associated glomerulonephritis, acute dyspnea with infiltrates on chest X-ray, raised lung transfusion for carbon monoxide, KCO, treat with high dose steroids plus cyclophosphamide. Organizing pneumonia in systemic lupus erythematosus can occur. The organizing pneumonia, as we know, is a disease of usually of unknown cause, but can occur in systemic lupus erythematosus, and it is characterized by plugging of alveolar spaces with granulation tissue that may also extend up into the bronchioles. In addition, organizing pneumonia can occur in the context of other diseases, and the usual use of the term bronchiolitis obliterans organizing pneumonia is no longer recommended as it erroneously or erroneously suggests a primary airway disease and is easily confused with bronchiolitis obliterans, which is a distinct disease. The clinical feature typically short, below 3 months, history of breathlessness and dry cough, and often malaise, fevers, weight loss, myalgia, often presents as a slow to resolve chest infection, and frequently after several courses of antibiotics. Breathlessness is usually mild, although a minority of patients experience severe breathlessness with rapid onset of respiratory failure and sometimes death. Examination may be normal or reveal crackles, and the clinical picture of systemic lupus erythematosus well present with the organizing pneumonia if associated. The drug-induced lupus, the causative drugs includes isoniazid, procainamide, hydralazine, caridine, minocycline, and penicillamine, and anticonvulsants. That's all about pulmonary disease in systemic lupus erythematosus.